Good evening, everyone. So, I'm Dr. Archana Mishra, and I'm having the questions which you people raised while going through this syllabus or course. Uh, should I take the name of the doctor and question, or should I start with the question and the answers explanation? Okay, so first question which was raised: how to precisely place calipers for uterine artery or umbilical artery in a Doppler. So to visualize arteries, usually you should put the probe in sagittal and then below the epiphyseal sternum, and then you rotate it to the transverse section where the cut section of the vessels will be visualized. So uterine artery will be along the cervix, and umbilical artery will be towards the fetus, umbilicus, and the placental insertion, where you can see the lumen, which is echogenic because it will contain the blood. So probe position should be below the xiphoid, and you rotate it in transverse section, and cut section will be seen at the as the vessels. Then one question was there: how to differentiate between the corpus luteal cyst and the, like, how to differentiate between the corpus luteal and ectopic pregnancy. So basically, corpus luteum cyst, which if the pregnancy, if she has conceived, so it will continue to secrete estrogen progesterone hormone, and there will be inside collection because of the secretion, and it will be thick walled or fire of ring appearance, where there will be increased vascularity in corpus luteum cyst. Whereas in ectopic pregnancy, you will have the typical gestational sac, which is also smaller in diameter, but you can see the ectopic pregnancy in the uterine cavity. Endometrium will be thick, which is the sign of pregnancy, and you will see the gestational sac, which is different from the corpus luteum cyst. And usually G sac in the cavity, if there is G sac is not seen in the uterine cavity, you will look in the adnexa, where along with the gestational sac, corpus luteum cyst will also be there, and on color Doppler there will be ring of fire sign, and inner margins will be somewhat crenated in cases of corpus luteum cyst. And in by blood investigations, obviously you can correlate with the ultrasound finding. There will be increase in titer in beta hcg in cases of ectopic pregnancy, and that's it. Then one more question was there, like, in ectopic pregnancy, if the beta hcg level remains static and can't identify the g-sac anywhere in the fallopian tube, so how much time one can wait? So, by if the ectopic pregnancy is not seen, no gestational sac is seen, and beta HCG level, as you all know, once the pregnancy is confirmed, beta HCG level or pregnancy test will be positive for up to 6 weeks. So, you have to monitor by the serial ultrasound and by doing the beta HCG level. And if you cannot find the gestational sac, actually this question is bit confusing. In ectopic pregnancy, if the beta hcg level remains static, this cannot be the case. Like, if the ectopic pregnancy is there, at least you should find the sac in the adnexa tubes or ovaries. And beta hcg level, unless you have given the methotrexate or managed by the medical management, it cannot be static. It will increase, or the ectopic pregnancy will rupture. Okay. Or how much time you can wait? You can wait till 6 weeks for the decline in beta hcg level. Then another question was, can we see a TEF? How? Like, tracheoesophageal fistula is very rarely it is diagnosed by ultrasound because it is soft tissue deformity. It is difficult. But as sign of esophageal atresia, one can see a small or absent stomach bubble. Because there is atresia and you cannot find the bubble, fluid is going out. It is not seen in the stomach. and it is the best diagnosed by MRI or 3D ultrasound. And similarly, like cleft palate or any soft tissue marker in cardiac pathology, also it is difficult to mark by plain ultrasound. You have to go for higher ultrasound 3D or by the MRI scan. Then large stomach bubble size. This is basically stomach bubble is seen in the upper part, and it signals the, if it is large in size more than 2-3 centimeter, it signifies the somewhere it is like obstruction is there in small intestine. Then retrograde accumulation will be there, and you will find large stomach bubble sign, that is in cases of intestinal obstruction, and indicates annular. Some other differential diagnosis is sometimes annular pancreas or malrotation. Okay. Then what is double bubble sign? What happens along with the stomach if the duodenal is also seen? Two double bubble sign is seen on the ultrasound. That is find it because of the enlarged stomach and dilated duodenum, which suggests duodenal atresia, again blockage. A significant finding in the Down syndrome or other congenital anomalies. When there is atresia in the small intestine, large bubble sign will be seen. When there is duodenal atresia, then you find the double bubble sign, one of stomach, another of duodenum. Another question, small intestinal loops, do they look like multiple bubbles if probe is tilt like lower? Yes, because small intestine is, very large in centimeters, and multiple loops are seen, but those can be compressible, and it shows peristalsis. Like you can see the peristalsis, and diameter will be less than 3 centimeter, and it will be thick walled, usually 5 layer, but on ultrasound 2 layer is seen, bright inner and the darker outer ring. Then comes the gastrochisis. So gastrochisis is defect in the anterior abdominal wall of the fetus. Usually it is 2 to 4 centimeter, where there is herniation of the intestinal loops. You can see free loops in the amniotic cavity, that will be seen. And a condition where intestine protrudes without a sac, usually towards the right side of the navel, it comes out. And omphalocele, it is commonly an omphalocele. Then another question was how to identify fetal bladder. Again, like in any normal anatomical structure, above the pubic symphysis, you place the probe and you try to find the anechoic region, which is bladder. That is, and to demarcate it more accurately, so above the pubic symphysis, you have to see in a sagittal section and aim just above, which is the fluid filled bladder will be seen. It will be black anechoic. And if you want to see, you can see the filling, confirm it by the, it will be size will be more if you ask the patient to wait and re-examine. In cases of fetus, you have to go above the pubic symphysis and look for the bladder. Then in fetal spine, one has asked about the banana sign. So these are again seen in the congenital spinal abnormality defect, like spina bifida. So you see the lemon sign or the banana sign, where there is inwardly scalloped fetal skull, and because of the accumulation of fluid, usually seen in the Budd-Chiari syndrome too, the cerebellum will be because of the compression, it will be seen like the banana shape, semicircular, curved on USG. That is the key finding in Budd-Chiari syndrome or open spina bifida, resulting from the low cerebrospinal fluid pressure due to spinal defect. Then one has asked about the RPOCs. Again, if the patient has history of incomplete abortion, or she is complaining of bleeding, pervaginal irregular bleeding, and she has taken any medical abortion pills or undergone the DNC procedure, if she is complaining, you do ultrasound, and if some bits of the products of conception is seen in the uterine cavity, it will be seen like echogenic mass and thickened lining of the endometrium because she has conceived recently. And there will be increased in blood flow and increase in the thickness of the endometrium. And how to differentiate it from purely blood clots? Blood clots are avascular. Okay, but in RPOCs, you will see the color flow on Doppler ultrasound. How to differentiate between, I hope I am not going too fast, and it should be clear to all, like those who have asked the doubts. How to differentiate between umbilical artery and vein by using ultrasound findings, USG finding. So basically, the umbilical artery and vein. It, you all know vein is single, thin walled, and it contains the oxygenated blood, whereas artery is double and it contains the deoxygenated blood. So when you take the structure in the transverse diameter, you will see three vessels in cut section, and it will be the veins will be single thin walled and arteries will be two thick walled. And again, the pulsations, the arteries showing the higher velocity and pulsality waveform on Doppler. When you see the Doppler, you can see the pulse higher in arteries. So differentiate between again uterine and umbilical artery. Subchorionic bleed. So, subchorionic bleed, when you do the ultrasound and you localize the placenta between or behind it, between the membrane of the like uterine layer and uh, placental bed, there will be anechoic collection, black in color. That signifies subchorionic bleed. That there will be collection, anechoic collection, which reflects the presence of blood. Unicornuate uterus, again, while doing the ultrasound, you trace the uterus, fundus, and by this side, you just change the probe direction and you find another globular projection that you can mention as unicornuate. Again, the MRI is the best, or SIS, saline infusion, you can see. In TVS, sometimes ovaries are not seen in post LSCS. Post LSS, that depends in how many days you are getting it done, because uterus is enlarged too much and immediately after cesarean section it will be like, unless preterm is achieved, it's 18 to 20 weeks. So it is difficult to localize the ovary. And why you want to see ovary, like if you want to rule out any pathology, better to get it done after 1.5 months to for more accurate diagnosis. Corpus luteum, bilateral corpus luteum, corpus luteum cyst versus simple ovarian cyst. Again, already we have discussed this.
If candidates have any doubts, they can raise their hands. Like there will be an option for raising a digital hand, so can raise their doubts. So faculty will be addressing the doubts directly. There will be an option for raising a digital hand,
Mm.
so you can raise the hand, so we can unmute you. We'll be waiting for 1 minute. If anyone of you have any doubts, we can come forward, please. Ma'am, we have a doubt in the chat box from Dr. Sweda. How to give score for biophysical profile?
इसमें तो बहुत सारी चीजें देखते हैं, तो
Okay,
कैसे
we'll do one thing. We'll wind up the session for now, and we'll be
उसको
addressing the
बस
second question.
बता.
Okay, ma'am.
Okay, one question was there in chat box: how to give score for BPP,
Biophysical profile.
biophysical profile? Yeah, actually, there are many parameters you see in this, and this will have to cover in a lecture where you can see like amniotic fluid, fetal breathing, respiratory rate, and all those parameters are seen. AFI for complete score.
Okay, thank you, ma'am. We'll be addressing the other question, and the next sessions will be announced soon. Thank you so
One
much.
more, how to differentiate between thickened endometrium and RPOC after MTP. Okay, in cases of thickened endometrium, the margins will be regular and you can see the trilaminar pattern. Endometrium will be thick, so outer, inner, middle margin you can see. But in cases of RPOCs, there will be irregular collection of the mass, like products of conception. It will be irregularly dispersed. It will not be uniformly ecogenic in structure. That you can see RPOCs and thickened endometrium. Again, in hemorrhagic and simple cyst, one more question is there. Simple cyst will be uniformly distributed, like ecogenicity, and in cases of hemorrhagic, because of the presence of blood, there will be mixed ecogenicity. You can see some white flecks in between the black picture. So there will be heterogeneous picture in cases of hemorrhagic cyst, and in cases of simple cyst, it will be uniform ecogenic picture will be there.
Thank you so much, ma'am. We will be announcing the next section soon. Thank you all. Bye.
Okay, thank you.